Happy Martin Luther King Day, everyone. I'm trying to get ahead so that you guys have everything for next week. So yes, I'm in my office on my day off to try to get this done. So let me go ahead and share my screen. And now remember, I will actually be gone for this lecture. So this will be audio recorded. And once again, I will try to keep them brief to about 15 minutes for you to be able to absorb. And then, so it'll be broken down into 2 15-minute lectures. All of what we're about ready to cover with vascular syndromes is literally things that you should remember about pathophysiology and neurophys. So some of it hopefully is not going to be new, and hopefully most of it's going to be repetitive and review, but you may need to go back in and understand the information for all the different syndromes. Unfortunately, some of it's memorization, but if you think about in the brain where the structure is that's involved, then it'll start to make sense. So you're going to be back in neuroanatomy, neurophys this week. Let me see what happens when I make it a big slideshow. And so I don't like that. Let's see if I can do this. There, that's what I want. Okay, so vascular syndromes, the difference between CVA and aneurysm, and we're going to go through some of the pathophysiology. I'm trying to get my slides to advance. There we go. So here are the objectives. So at the end, you should be able to do this. Describe the etiology, clinical manifestation of stroke, pathophysiology, the difference between the different types of stroke, and then identify stroke syndromes based on their compromise for clinical decision making, and really for what patient presentation is going to be. And so if we remember, when somebody is suspected to have a stroke, we need to act fast. And so if they have facial drooping, arm weakness, speech difficulty, it's time to call 911. So any point in time, that is our responsibility. So what is a stroke or a cerebral vascular accident? It's an umbrella term in which blood flow to the vessels become disrupted either from clotting or rupture. So you can have something that is ischemic versus something that is hemorrhagic. And so as you can see, what happens more often? Ischemic strokes 80% of the time. Hemorrhagic is about 20%. And if we looked at prognosis, so remember those prognosis factors, hemorrhagic CVAs are definitely more fatal. So prognosis is less favorable with those types of strokes. This is just a depiction of what it looks like. Ischemic, you can see occlusion of the artery happens and you've got surrounding cell death. Bleeding is hemorrhagic, and so when that happens because of increased pressure in the vasculature walls or weakened walls, you can see the bleed then goes into that area. When the bleed happens, think about this. The bleed's going to happen and it's going to increase intracranial pressure, which then can cause an associated shift of the brain tissue. Risk factors for having a stroke: having a history of atherosclerosis, hypertension, any types of cardiac disease, and arrhythmia. So history of AFib or having atrial fibrillation puts you at an increased risk of having a CVA, which is why typically they are on some type of blood thinners. If you have diabetes, metabolic syndrome, and look at this. This is the big one. Trans-ischemic attack, which is a mini stroke. So it's temporary symptoms that go away and there's no evidence on imaging. But if you have a TIA, you are now at an increased risk, over a third of a risk to have a future stroke event. So that's a huge precursor that we need to talk to our patients about. So what really happens with the CVA? We get a lack of oxygen to supply to the brain. Irreversible damage to the brain begins after 4 to 6 minutes, which is very quick. So you can see here, this is where the area of infarct is, and they have a little bit of what? A midline shift because it's not fully symmetrical. So the left hemisphere has shifted into the right hemisphere. Once the infarct happens, then you have cerebral edema and swelling. And so that can cause increased intracranial pressure as well. Not only with hemorrhagic, although it happens more rapidly with hemorrhagic, but also with ischemia as well. And so thrombolytic strokes. So what's the difference? Thrombi or clots form by plaque and development in a vessel wall. Most common type happens secondary to atherosclerosis. look at all the different common sites, carotid arteries, vertebral arteries, and occur over several days. So they may start to feel a little off, and it happens over days because that atherosclerosis builds up, and that narrowing gets smaller and smaller. You typically see this in older persons, and it's not associated with any type of exertion or activity, and it can occur when the patient's at rest. Preferred sites, just to follow up with that, you can see all the different areas and the vasculature of the blood supply. And so death of a portion of the brain happens. You can see the blood clots form and you get occlusion. And so because of that occlusion, you have cell death of brain tissue. We talked briefly in class previously last week about lacunar infarcts. They're only small clots located in deep regions of brainstem and subcortical structures. So it's not on the surface of the brain up where the motor homunculus is. Found in deep penetrating arteries, most commonly look internal capsule, basal ganglia, and brainstem, result from much smaller occlusions of the branches. And because they are small, they do not cause severe physical impairment. Physical is the key word for that. So if you look here, look at those deep penetrating arteries, you can see how small they are. So it really isn't affecting a very large, rather than the MCA on the outside, which is much more important structures of the motor homunculus. Embolotic strokes, a little bit different, are clots that dislodge from their original origin and travel into the cerebral blood vessel where they become trapped. Typically affects smaller vessels like the MCA, and sudden onset associated with presence of cardiac disease. So this is where you may potentially have somebody with atrial fibrillation, a little clot breaks off and goes through the blood supply and gets stuck in one of the smaller branches of the cerebral blood flow. So a little bit different, you get something that embolus that breaks off and it goes and gets caught. And so this is just a little bit different depiction, but you can see on the picture how it's a little bit different than thrombolytic is the atherosclerosis buildup versus the embolotic is it's traveling and then gets stuck. Now, to contrast, hemorrhagic stroke, frequently fatal. That's your biggest thing. If they survive, prognosis is generally good. Involves bleeding into the brain tissue after a rupture of a vessel wall, typically secondary to aneurysm rupture, or if there happens to be an arterial venous malformation in the brain that nobody knew about. And so I think I told you about one of my patients that happened to. Results in edema and compression of brain tissue, and it can occur suddenly, and this one is associated with exertion and activity. And so that's the difference. So if we look, we've got a little bit of a break in the wall of the artery, so you get surrounding blood flow that now hemorrhages into the brain tissue. So an aneurysmal subarachnoid hemorrhage. So an aneurysm is a bulge occurring in a blood vessel wall as a result of a clot formation. So most aneurysms are small, called baryaneurysms. Baryaneurysms commonly occur in that circle of Willis, and they tend to enlarge with time and weaken the vessel walls until the rupture occurs. So let me show you a picture. So this top here, you can see of the different types of aneurysms. So you can have a fusiform, which is the whole structure, a saccular, which is like a little bubble on the outside, and then what happens when it's ruptured. Often the treatment for an aneurysm, if they know that they have it or if it's detected, and the only way to know that is through a MRA, which looks at the blood supply of the brain, is aneurysmal clipping. So it looks like a little paper clip, and they go in and they clip off the aneurysm. And so basically they make it so that it's at decreased risk for rupturing, and now we've got free flowing where the blood isn't getting caught in that little aneurysm area. So here's the TIA depiction. I know I talked previously about it. It is a mini stroke. Less than 24 hours of signs and symptoms. Typically, they last 1 to 2 hours. Still coming from atherosclerotic disease and emboli, and it's a warning of another stroke. And so you can see here, transient is just a little piece breaks off and where the blood flow isn't fully occluded, but it might have become occluded and then the little piece breaks off, which restores blood flow versus a complete occlusion. So signs and symptoms of the mini stroke. Numbness or weakness of face and arm or leg, sudden confusion, trouble speaking or understanding, trouble seeing, dizziness, or walking. So don't ignore it. We want to make sure that we're getting checked out if that is the suspicion. All right, common areas of arterial occlusions in the cortex. So we've got the MCA, and then we've got the PCA and the ACA. So you've got to go back to your info. I can't reteach some of this. But if we look, anterior cerebral artery is pink, middle cerebral artery is blue, deep branches are purple, and posterior cerebral artery is the yellow. And so if we look at the motor homunculus, we can see, if we look at the MCA breakdown, what do we have? We've got the shoulder, elbow, wrist, and hand, and then we've got parts of the face. So there should be or may be some facial drooping or weakness as well. And then if we look at the back, and in the PCA, look at swallowing and tongue, right? So that is going to be, PCA is going to be more of the posterior, more swallowing, tongue control. It also supplies the brainstem, which is where the cranial nerves for that control happens. And then if we look at the ACA is what? We look through the trunk down to the lower extremity. So that should really make sense. Come back to this for you to have a conceptual understanding and not just memorization when we get into the syndromes. And so just as a reminder, here are all the way the circle of Willis works and how all the branches come off. And where the spinal cord also has some different types of blood supply. Remember, you can have a spinal cord stroke. And one of our patients in neurowellness currently has a spinal cord stroke. All right, so I am going to start talking about neurovascular syndromes. I'm going to stop here. So that's more pathophysiology, and then I'm going to go into common syndromes presentations for the next one. So take a break, go back and review before we get into this next one if you feel like you need it, and I will see you in just a bit. I'm going to stop sharing.